The surgical management options for infants with Pierre Robin sequence, establishing a standard. So Pierre Robin sequence, or as I'll refer to it, PRS, involves a sequence of disorders in which one developmental abnormality leads to a subsequent abnormality. Here, the hypoplastic mandible or retroposition mandible results in posterior tongue displacement that disrupts normal respiratory and feeding function. And the condition is often associated with a wide U-shaped cleft palate. Although PRS can occur in isolation, known as isolated PRS or IPRS, it often occurs in conjunction with other syndromic diagnoses. Syndromic PRS, or SPRS as it's called, describes PRS infants with concurrent diagnoses such as Stickler syndrome, velocardiofacial syndrome, and Treacher-Collins syndrome. Those are the most common, but there are also others. And the estimated incidence of PRS has previously been cited at between 1 and 8,000 or 1 in 14,000 births, but there have also been recent studies in the US, Netherlands, UK, and Ireland that actually cite this incidence at or between 1 in 5,000 and 1 in 6,000 births. So treatment begins conservatively and progresses towards surgical management depending upon the degree of airway obstruction. Conservative management includes non-invasive techniques like prone positioning, placement of a nasal pharyngeal airway or CPAP for those requiring additional airway support, and feeding supplementation can be achieved by the placement of nasogastric or gastrostomy tube. Although most infants with PRS can be managed conservatively, surgical management is required for unresolved severe airway obstruction. And these surgical interventions include tracheostomy, tongue lip adhesion, and mandibular distraction osteogenesis, TLA or MDO. Tracheostomy was the first and sole mode of airway management for many years, but it is associated with significant morbidity and mortality. TLA, this procedure aims to correct glossoptosis by moving the base of the tongue anteriorly and anchoring it to the lower lip, while MDO provides advancement and prolongation of the mandible, correcting the micrognathy-induced glossoptosis. And just some recent trends that have happened. There was a landmark paper in 2016 where polysomnography data monitoring obstructive sleep apnea, or OSA, became routinely recorded as a diagnostic tool and therapeutic marker for airway resolution. So that's been occurring over the past decade, and this data includes the apnea-hypopnea index, or AHI, as well as the O2 nadir. And these values allow clinicians to objectively quantify the degree of upper airway obstruction and establish standards for treatment success. And currently there isn't a gold standard in surgical management for PRS. Surgeons have been performing MDO more frequently over the past decade, but there still remain global and regional variations in which treatment is preferentially selected. So this paper, given the scarcity of literature and the outcomes comparing MDO and TLA, and also the recent new trends in defining and analyzing airway resolution, this review aims to comprehensively analyze and evaluate the most recent data regarding airway and feeding outcomes for both MDO and TLA. As such, this paper is intended to aid surgeons in the decision-making process when surgically managing PRS patients. So a systematic review was conducted across multiple databases to identify all studies published in English that reported outcomes of MDO and TLA for the treatment of PRS. Importantly, we only included studies with cohorts of greater than 10 patients and with a follow-up duration of at least 1 year to improve the validity of the study and ensure all pertinent outcomes were recorded. And with that, we gathered 22 studies that were either MDO or TLA cohort studies or MDO and TLA comparison studies. So, like I said, in 2016, when that landmark paper came out, there was a what was dubbed OSA relief was one of the markers to determine a successful resolution of sleep apnea. And it's defined as an AHI of less than 5 with no need for additional surgical intervention. And by this standard, comparison studies showed that 96% of MDO patients experienced successful resolution, while only 48.8% of TLA patients experience successful resolution, so nearly double. And this is where it starts to get interesting. All MDO cohort studies that were analyzing AHI showed significant differences between pre and post-operative AHI, while none of the TLA cohorts did. And the same goes for the O2 nadirs. All MDO cohorts reported O2 nadirs showing significant differences pre and post-operatively, while TLA patients did not. Additionally, both cohorts showed both MDO and TLA showed over 95% avoidance of tracheostomy. So both can improve airway obstruction to the point of preventing tracheostomy, but the PSG data or polysomnography data paints a more nuanced picture distinguishing the two. And for our feeding results, we had multiple MDO cohort studies showing 100% achievement of full oral feeds within 1 month of surgery, while the latest and largest TLA cohort study fell well short of this metric by 18 months. For growth and weight assessments, comparing weight percentiles against controls or the WHO standard, also weight for age Z-scores, there actually weren't any significant differences between MDO and TLA, both similarly achieving relatively normal weights by ages 1 to 2. So both are able to improve infant growth and weight, but in terms of gastrostomy tube prevention, 80% of MDO patients avoided gastrostomy by latest follow-up, while less than 45% of TLA patients were able to do so. And other results, the reoperation rate of MDO was 1.5% compared to TLA, which had an 11% rate of reoperation. The mortality rate was also slightly more favored for MDO, although it is very close. In terms of complications, MDO patients largely experienced infections, as did TLA. However, TLA patients experienced relatively fewer minor complications because there were some MDO patients that required device realignment as well. So in discussion, the advantages and disadvantages. TLA, it's very simple. It provides immediate relief of airway obstruction with relatively fewer minor complications. However, it does not correct micrognathia, and it relies on mandibular catch-up growth to fully achieve long-term airway stabilization, whereas MDO provides advancement and prolongation of the mandible to correct the micrognathia-induced glossoptosis. However, it requires specialized surgical training and equipment. The distraction process requires intensive care monitoring and subsequent operation for hardware removal. And I just wanted to discuss a few trends. The decision to perform MDO versus TLA is influenced by surgical expertise, but surgeons have been performing MDO and PRS infants at progressively higher rates. The ACPA and International Society of Craniofacial Surgeons in 2018 noted that about 74% of surgeons preferred MDO compared to the 13% that performed TLA. And we can compare this to the ACPA findings in 2010, where 48% of respondents performed MDO compared to the 28% that performed TLA. And this trend is most notable in the United States, where nearly 82% of surgeons favored MDO. However, in non-US countries, they continue to use MDO, TLA, and tracheostomy more evenly. So 39% versus 19%. And also for tracheostomy, it was about 31% internationally. So recapping the polysomnography data, the AHI and O2 nadir, MDO showed significant improvement in all studies, while TLA did not. In comparison studies directly comparing the two with the OSA relief, there was nearly a double success rate for MDOs compared to TLA. Moreover, the rate of reoperations was markedly lower for MDO at 1.5% compared to 11% respectively. So the polysomnography data and the rate of reoperations heavily favored MDO over TLA. For feeding, both MDO and TLA improved feeding function with similar growth and weight assessment at ages 1 and 2 years, depending upon the study's parameters. But where we start to see distinctions are with the achievement of full oral feeds, where MDO patients often can exhibit 100% achievement very quickly, whereas for the TLA patients, it takes more time. And also the avoidance of gastrostomy, where the vast majority of MDO patients were able to avoid it, while most TLA patients require gastrostomy tube placement. And here's some other miscellaneous outcomes from some of the included studies. Multiple of these studies found MDO normalizes the mandibular body and condylar positioning to the point where it actually mimics normal development shortly after distraction at about 1 year. There were also multiple studies that showed significant improvement in direct laryngoscopy grading in the year following MDO, which increases the safety and stability of the airway at home and for future operations. And there were also studies showing that MDO is uniquely effective for syndromic PRS patients, touting its role in resolving complex cases, which is important because recent literature finds that syndromic cases likely outnumber isolated cases. But there are also papers that investigated predictors of failure for MDO, which we can see here to offer guidance in situations that warrant caution. These unique clinical scenarios, one of them was the combination of neurological impairment, low birth weight, and syndromic status. And another was the combination of CNS abnormalities, laryngomalacia, and preoperative intubation. These things are predictive of MDO failure. So in conclusion, this review of the latest literature regarding the efficacy of MDO and TLA in treating PRS infants, our data reveals a more nuanced distinction regarding the resolution of airway obstruction in favor of MDO versus TLA. With routinely documented polysomnography data, MDO exhibits superior resolution consistently of airway obstruction that is more stably maintained, as indicated by the lower rate of reoperations and laryngoscopy data. And although minor complications seem to be more frequent with MDO than in TLA, our data reinforces previous notions, suggesting MDO superiority in time until and overall achievement of oral feeds, as well as in gastrostomy avoidance. And that's it. Thank you.